Glad to have you here. I will let you take it away.
Thank you so much, Sarah and Victoria for having me here today. It's really exciting. I went on, when I learned about this series, I went on and checked out the earlier talks in the series, and you guys have a great conversation going here. So I'm really honored to be part of it and hope to learn from you as we have a conversation today, because it's, I really hope that we do have some give and take, and it is lovely to see some familiar faces and names and headshots on the screen here. Let's see, I am going to share my screen. How's that? Can you guys see?
You can see your slide and your Zoom window.
How about now?
There you go.
Is that better?
Yep,
okay.
That looks good.
All right. And Sarah is going to be my chat monitor for this session. So Sarah, please interrupt at any time if there are questions that come up or comments you guys want to make. It's more fun for me if you go ahead and put it in the chat, and there will be a time at the end when I'll ask people to unmute to make comments. Today we're going to talk about how embedded research can make an impact in a learning health system, and embedded in that question is that we don't take it for granted that as embedded researchers, we are making a difference. I'll be talking about the experiences we've had at Kaiser Permanente, Washington, where I am one of 3 directors, along with Katie Coleman and Emily Westbrook, of a center called the Center for Accelerating Care Transformation, which has been the petri dish for a lot of this work. Let's see, advancing slides is important. Okay, these are the objectives for today. We're going to talk about what gets in the way of embedded research getting adopted, and then talk about some activities that we can do to promote adoption, and then look at what we need in a health system to make those activities. Acknowledgements are many. This is definitely a case of it takes a village, and the people on the screen have varied skill sets, a whole bunch of different researchers, quantitative and qualitative, some clinician scientists, project managers who understand how to do this kind of work, data analysts, of course, our patient partners, the care teams, health system leaders across the different projects that we'll be talking about today. And the message here is that the partnerships are really foundational. So I went back and viewed the series that Drs. Trinkley and Gilmartin gave in this venue back in September. I wanted to put this talk in the context of that really nice introduction to learning health systems. So you can see the definition of a learning health system and the definition of a learning health system researcher written up there. And the bold parts are what we're going to talk about today. So what are the best practices to seamlessly embed these into the delivery process? What are the ways to embed best practices into the delivery process? And what do researchers do that assist with that rapid implementation that has the effect of improving outcomes? The other messages that came out of that first seminar in the series was that, in fact, there are systems, health systems that are using LHS models, but there's no single standard, right? I mean, those of you on this Zoom who are in health systems that aspire to be learning health systems. Each of you has a different manifestation of that ideal, and even the unit at which the level at which LHSs operate on. Sometimes we're talking about a unit within an organization, a community, or even at the level of policy. So we can talk about LHS at all of those levels. And there are lots of components of a learning health system, and any one system may emphasize one over another. So dissemination and implementation science, informatics, data and analytics, stakeholder engagement, QI, precision health, those all come through in different measures, different proportions in different learning health systems. Finally, we're all sort of on a developmental continuum and aspiring to get to this learning health system ideal. So in that context, the starting point for this conversation is that there is this conventional wisdom that embedded research magically results in impact, right? That we do this beautiful piece of research, we publish it, and then it leads to adoption and sustainment of our research findings, and we get improved health and all of those desired outcomes. And we know that it's more complicated than that. We find that the learning health system provides a lens for understanding the gap between research findings and these improved outcomes at scale. So our team at the Center for Accelerating Care Transformation was interested in examining the structures and processes that are needed to bring the LHS to life. And because we were getting asked by our health system to be an LHS, we wanted to hold ourselves accountable for doing what our leaders had asked us to do, and needed first to define what it is that makes up the LHS that we are building, and then measuring it. So the paper that's cited here is our attempt to lay the foundation for measurement. We reviewed the literature and found 17 papers that described either fully formed LHS models or listed some key core constructs of an LHS. And we reviewed them and selected constructs based on a number of criteria, and pulled them together into a model that I'm going to share with you. Of all of the papers that we identified, the Geisinger Health Systems paper from 2015 that had 9 operational components of an LHS was the one, it emerged as the one that sort of had the most, it incorporated most of the existing constructs. So we used that as our starting point and then built from there. We compared the components and that we saw in these papers to our experiences, and tried to sort of fill in the gaps, and worked to clarify some definitions, and there were some places where there was overlap. This was a whole iterative process of tidying up, reducing redundancy, and in the end, our logic model, which I will share with you in a minute, includes 24 constructs, 6 inputs, 9 outputs, and 9 outcomes. And I will say in this group that the next step is measurement, and we would welcome other groups to contribute to the development of measures across these 24 constructs. I know that that's work that's ongoing in many groups right now, but there is a lot of work to be done in this space. So these are the inputs, outputs, and outcomes that we believe are essential for becoming a learning health system. On this slide, we're going to focus on the outcomes because that's what drives the idea of a learning health system, is that what are the outcomes we're trying to achieve. And in subsequent slides, as we go through the two stories we're going to talk about today, we'll dig into the inputs and the outputs. So knowledge to action latency, this gap between when we know something and when we actually act on it, is something we want to hold ourselves accountable. The adoption of evidence-based practices is actually part of the definition of the learning health system. So we felt that was important to keep in there. And elimination of waste was commonly cited in our literature review as an important outcome of an LHS. The next 5 that are listed there are the quintuple aim: population health, care experience, cost, care team experience, and equity. And finally, if our organizations are investing in becoming a learning health system, we feel it's important to hold ourselves accountable by looking at that investment itself and what is the return on investment for that infrastructure and that goes into becoming a learning health system. So now I'm going to tell you a couple of stories from Kaiser Permanente, Washington. The first one is the community resource specialist story. This was a research study that was PCORI funded, led by an investigator named Clarissa Hsu, which I think some of you know. The study was called Learning to Integrate Neighborhoods and Clinical Care, or the LINK study. And the LINK team partnered with patients and care teams and did a collaborative process for designing a role that met the needs of patients with regard to social health. And the CRS role did a couple things. It helped patients who had social needs address those, and both by providing information and connecting patients to community resources. And there was also a set of health coaching activities with action planning and that sort of thing. The team did a pilot implementation in 2 medical centers that had populations with higher social needs, and an evaluation that was all part of the PCORI funded activities. And Clarissa's paper is cited at the bottom of this slide. So the evaluation was mixed methods and had really promising findings. In these 2 clinics, 1,200 patients were referred. Most of them had at least 1 visit. They tended to be older, have more chronic conditions, be high utilizers. Majority were female, and they had diverse race and ethnicity. There was a high degree of patient satisfaction. Other members of the primary care team valued the role, and we learned that a lay person was appropriate, that describing this role as having a lay person background was appropriate, and that these CRSs were able to fulfill the role without clinical training. And at the end of this PCORI funded grant, the patients and the care teams all wanted the position to continue. So fast forward 6 years, and we have community resource specialists integrated across KP Washington in all 30 plus medical centers. They are seen as an essential part of the primary care team. You can go and talk to any of our primary care providers or medical assistants, and they know who their CRS is. They've talked with them numerous times. They've shared patients with them. They can't imagine doing their work without the CRS. There are stories floating around of patients who benefited from the work of a CRS who helped connect them to rental assistance, who helped connect them to social support around a chronic condition. help them apply for services that they didn't know they were eligible for. These stories are commonplace and visible, and the leaders in our organization, our executive leaders, talk about them when they do staff calls or when they go out to our stakeholders in the community. So it's become part of the brand of our organization. And in fact, this year we got the National Alliance of Healthcare Purchaser Coalitions gave us something called the Evaluate Innovation Award for this work. And now as we go into 2022, our team is doing some work around universal social needs screening, and that's being built on the chassis of the community resource specialist. So this is a success by any measure. And the question is this a triumph of embedded research? And what do you think this learning health system did to make this happen? So if you have some thoughts about what you think happened between this slide and this slide, put them in the chat. Of course, I cannot see the chat, so I will depend on Sarah.
As people maybe drop their thoughts in the chat, Paula, we do have a question about measuring the return on investment for this kind of program. So we know there are lots of challenges for measuring, but how have you operationalized and thought about that return on investment for the program while people are sharing some of their other thoughts?
Yeah, so we talk about this a lot, and we haven't developed a measure for this yet, but it has a numerator and a denominator, and so we talk about that investment, the denominator of ROI, with our leaders, and we remind them when we have projects that we're working on, that we have a budget that they have given us, and it is a generous budget, but it is finite. And whenever we're working in partnership with our leaders and they ask, well, could you go in this direction? Could you do more of this? Could you do this for longer? Could you go deeper in this? We're telling them, do you want us to do that? And if so, what does that mean about the other things that other stakeholders are asking us to do? So we're very much having conversations about the amount of investment and making sure that it's top of mind, that the leaders feel that they are getting their money's worth for what they are doing. And I think that a lot of the numerator of that investment may come from the other outcomes that you see listed there. So it's, how much health were we able to get? How much waste were we able to reduce? How much were we able to improve care experience and reduce burnout for that investment? So definitely a work in progress. I would love to hear if anyone on this Zoom has had thoughts about how to measure ROI.
Paula, we have one comment in the chat suggesting that you maybe use trial and error, ongoing adaptations, or maybe audit and feedback in making this happen. So I'll let you continue from there.
So adaptations and audit and feedback. Yeah. Great. Well, those are not entirely far off. I'm going to walk you through how this came to be through the model that we talked about. So first, we're going to talk about the key activities that we did at Kaiser Permanente, Washington, to make it possible for the CRS role to get adopted after the study ended. And after we talk about the activities, we'll go and look at what were those fundamental, the inputs that we needed in order to do those activities. So the activities were mainly in two areas. First, implementation support. The Center for Accelerating Care Transformation helped develop CRS standard work and integrate the role into the primary care team. So this is a common barrier, right? That published intervention studies don't often provide guidance on how to operationalize the intervention. And this was a brand new role that hadn't existed before in our system. We had to help the team, help the care teams figure out how this was actually going to be scaled up. We had practice facilitators who we sent into the medical centers, and they worked elbow to elbow with the community resource specialists in the medical centers to design workflows and conduct PDSA cycles. And one deliverable from this was an implementation handbook, which is available on our website. It's intended locally for our context, but if you're interested in this type of work, it's a really nice example of some detailed thinking about what it takes to integrate this role into the primary care team. The other area where we focused was evaluation. So the PCORI grant had an evaluation, and I shared some of those findings with you, but it was 2 pilot sites, very small evaluation. We were challenged in looking at outcomes because of the numbers and the time frame. And honestly, in this whole area, it's very hard to move a needle on health outcomes. So we really felt like there was a lot more that we needed to understand as we rolled out this CRS role and went on to really inform future decisions about the CRS program. So the ACT Center collected, analyzed, and interpreted data to inform these operational decisions. We were acutely aware that real-world results often fail to live up to the findings of peer-reviewed publications, and wanted to help the care teams and the leaders to come up with metrics to track the effectiveness of the intervention and its implementation. So these were the 2 main areas that we focused on. The inputs, we needed input, all 6 domains of inputs came into play here. And we leveraged all of these heavily. So I think of this category here as this is the fertile soil, right? These are requirements, and if the embedded research are the seeds, then this is the fertile soil and the water and all that. So first of all, people and partnerships. Our research institute, long before the ACT Center existed, our research institute had long-standing partnerships with leaders in mental health and wellness. And mental health and wellness, for reasons that we can go into if you're interested in, is the group that hired the community resource specialists. They function in primary care, but they reported up through mental health and wellness. So those long-standing partnerships were part of the foundation of our work. Health information infrastructure, we relied heavily on Epic analysts to help develop workflows in our electronic health record. This third one, prioritization, this was absolutely key. And without this, we would not be having this conversation today. The decision to hire 30 CRSs came about not because we took the findings of this PCORI study and went to the leaders and said, see, this is fantastic. We think this is going to be a wonderful addition to the primary care team, and you really should hire them because we did the study right here in your own medical center, so you should adopt it. I would like to believe that that's what happened, but it is not. What happened was that at the same time, as we were finished, as the PCORI, as the LINK study was finishing up their work, another team that included myself was rolling out integrated mental health across Kaiser Permanente, Washington, and putting social workers in the medical centers to do integrated mental health work in primary care. As that was getting rolled out, and the social workers were practicing at top of scope, guess what happened with the other work that the social workers had been doing? They weren't able to do all that work. So it generated the need for someone else to come in and play in that space that the social workers were leaving behind. And when leaders looked around, they said, well, who else could do this kind of work? We just happened to have the CRS role there ready to go. And they said, let's hire 30. And we had said, well, we're in 2 medical centers. How about next year we do 7? And then the year after that, we go from there. And they, on a dime, said, they went from saying, well, it's very nice that you did this study, and now like we have no use for you, to now you have 30 CRSs all at once, which we had no idea how to implement, and we didn't know how to integrate them into the primary care team, and all of those questions came up. Funding is what I'll note from this is that we had, the extramural funding from PCORI is key. Like we wouldn't have designed the role without that extramural funding. But then everything that came after that was health system dollars. Improvement infrastructure, I mentioned practice facilitators. They have QI skills and implementation practice expertise, and they were the doers of this work. And finally, with ethics and oversight, it was important as this went from being a research study to being essentially a quality improvement project, that our IRB gave us guidance on how to make that shift and how to think about doing this work informed by human subjects principles, although it wasn't human subjects research. Okay, that's the first story. The second story is a little different. This story does not start with a single investigator-initiated research project. Instead, this is about researchers interested in LHS work who came together to talk about ways to use advanced analytics methods to translate evidence into practice across a range of topics. And in the interest of time, I'm not going to go into each of these, but you can see there the types of analytic projects that we worked on in partnership with health system leaders. We sat down with them and said, are there ways we could use risk predictions to better target interventions to the people who would benefit the most? So we worked in the area of influenza, reducing no-shows for appointments, and that was evaluated in a randomized controlled trial that is cited there. And then when COVID hit, we used a model to predict medically vulnerable individuals and reached out to them by phone to make sure that their needs were met. And we've got some other models in the works. So what we've learned from the advanced analytics work at the ACT Center is a few things. Validation of, so if there's a model that's been developed by other researchers or by, say, EPIC, it's important to test that model in our own population, and researchers know that, and sometimes our health system partners were not as aware of that need. So this really generated a lot of conversations about questioning models and making sure that the model is accurate and effective, and being aware of the possibility to perpetuate bias or health disparities because of the racism that is baked into our health systems and our data. So that's sort of an educational process that we're all going through together. We've deployed these models and had some success in those few areas that I've mentioned, and we're learning as we go. We also we have equipoise. We're always considering the possibility that implementing the predictive model does not result in the desired outcome. And we are always curious. If possible, we randomize, and if not, we do quasi-experimental designs. And then the last point I'll leave you with is that it's exciting to think about a risk model. So if you're working in a particular area like opioids, like if you have a risk model that can predict the people who are going to get in trouble with opioid overdose, it's very tempting to focus in on the risk model and how it performs and what its characteristics are. But we needed our health system partners to be thinking about the intervention design that was going to go hand in hand with this risk model, because the risk model alone is not what makes the difference for patients. It's what you are pointing, what the intervention is that you are pointing at the people with the higher risk scores. That's going to make the difference, and making sure that the model is designed with that in mind turns out to be a step we can't overlook. So that's a very different story from the CRS story, because here it was basically a methodology. We know how to do risk models. How might we actually improve care in our health system through validating and developing, validating, and deploying risk models in our own setting. Okay, so now we'll just spend a few minutes talking about these. Oh, sorry, I skipped. Yes, so I wanted to, we're not done with this story yet. I wanted to just, using the model, talk about what we did. So obviously the validation of the model was a key activity here, but even before the validation of the model, sorting through and figuring out data sources is not straightforward necessarily. So understanding where your data is coming from, and when you have choices about where you get the data, what the different implications are as you put that into the models, that was an important piece that we contributed from the Research Institute in this work. And the required inputs for that were data analysts experienced with utilization data, as well as we have a statistician who has an interest in learning health systems work and modeling, and a focus on equity. Evaluation, I mentioned that we did randomization where possible, and natural experiments, pre-post, depending on the situation, and then finally consultation at each for each of these models that we have worked on. Oftentimes there are other places where content and methods expertise have come into play. So from the research end, we've assisted with rapid literature reviews to synthesize the available evidence and guide model development. We've also helped with some of the technical aspects of understanding what the EPIC system, what the functionality that we need in EPIC in order to deploy the model. And we've also worked with our partners to help them design both the intervention and the implementation of the intervention. Okay, so now we're at the discussion portion of the talk. And I've listed here the definitions for these key activities. And I'm curious, as you look at this list of activities, which of these does your organization use to accelerate learning and improve outcomes? And you can put that in the chat. And if you'd like to unmute and share with us, what are some ways that your research activities, the program of research that you're leading, contribute to moving your organization toward being a learning health system? So I welcome your comments here and your experiences.
Please feel free to put comments on either one of those in the chat. I'll be watching those. If you also have something you want to share, please feel free to raise your hand or say in the chat that you want to jump in and talk. Love to have some of you join us in conversation.
Yeah, this is Chris Thurstone. Quick question around what are the initial investments to start something like this up? And what are the initial staffing investments that need to be made?
Yeah, that's a good question. I'll tell you about our staffing model. Our research institute, so the ACT Center is based at the Kaiser Permanente Washington Health Research Institute. KPW-HRI has about 70 scientists and 350 total staff, which includes the programmers, the project managers, the research specialists, et cetera. It's a soft money shop, like all of your research centers. And we go to our scientist colleagues with FTE. So we say, if you are a statistician and you have 10% FTE available and you're interested and you have skills in risk prediction models and you want to work with us on this project to predict sepsis or opioid adverse effects, then we will buy some of your time, right? We do that with project managers, we have our projects led by subject matter experts. And so we have an implementation scientist who's working on social needs screening right now. And so we've bought a chunk of her FTE. So we have a small group of people at the ACT Center who have 30 to 50% FTE covered, and that's like 5 of us who do the strategy and deploy the strategy of the ACT Center. But you know what? I have a good slide that kind of exemplifies this. We have a lot of people. See, that's our group in 2018. All of the people at the top there were funded by the ACT Center in that year. Those are all researchers, and people. The lower photos are from people who are care delivery partnerships. So to answer your question, we are able to, because we are in a soft money environment, we are able to get small amounts of FTE, but meaningful amounts from really talented scientists and programmers and other folks who are critically important for doing the work. They have the skills and we have the FTE to bring into it. When we started doing this work at Washington was in 2017, and every year since then we've gotten more than $2 million from our organization to do this work on an annual basis, and we just get flat funding and deploy that, and we seldom make it that allocation. Does that answer your question, Christian?
It does. Thank you very much.
I think it's really important to have the health system provide it at a programmatic level as opposed to project by project, because what happens is we get it programmatically. We get the program funded, and then we negotiate the projects with our executives. From our executives, we hear what are the priorities on a year-to-year basis, and then we work with operational leaders to say, is this feasible? Is that feasible? How do we want to do this? So we spend a lot of effort scoping our projects and getting the right staff on them, but we are not spending effort justifying each project and making the business case for each project and saying you need to fund this piece over here and this evaluation over there, you need to fund this. We have the funding, and that the ability, the faith that our health system leaders have in us to make choices with this investment is critically important.
Paula, as people are putting some ideas in the chat, we've heard that implementation support and evaluation are two activities that are commonly used. Can you maybe talk about which ones are maybe less commonly used and how you decide when to use these different activities in moving projects to outcomes?
So the less commonly used, I mean, I didn't give you examples of all of these. All of these that are on the screen here, or can you see the key activity screen? We've done all of these. I would say, I think they're all important to have in your skill set as a program. If you're going to be providing of service to the organization, I think implementation support is often a heavy lift. So we projects that where we are really trying to make changes, if you don't have implementation support, you're not going to get very far. And so that ends up being a big chunk of our investment. Is the practice facilitator model is the most prevalent model that we have used, because we're off right there in the flow of primary care. And these are changes that are very hard to make. They're not just add water, right? You need a human being with a skill set to be in there elbow to elbow working with folks. So implementation support is a big part. And evaluation, we are researchers and we need to have equipoise, and we need to hold ourselves accountable for this fantastic thing we put in practice. And we get adopted, and if we don't ask ourselves if we've met our goals, then shame on us, right? So we're really working to demystify evaluation. Like not everything needs to be an RCT. Like there are pragmatic, flexible ways of getting just the right amount of data to evaluate what we're doing. But the other things are important as well. Environmental scanning, we need to constantly be aware of what's happening and what best practices might be out there that we could learn from. And closely linked with that is evidence synthesis and translation. Some of us were part of the U.S. Preventive Services Task Force Evidence-Based Practice Center that does reviews for the USPSTF, which are very long and detailed and complex projects. We took those methods and boiled them down to the essential methods. We can do evidence synthesis in a 3-week period and answer questions about like, what's the best way to do X for our health system partners. And that can often, start a conversation that we don't need to reinvent the wheel, because oftentimes if you have a question about what intervention works for something, oftentimes there's a robust literature out there, and we shouldn't start from square one. I'm not going to go through all of these because we don't, have enough time, but I think that I don't want to give the impression that this is only about implementation support and evaluation.
So I have a question. Hi, I'm Allie Kemp. Kaiser is quite a different setup than we are living in here at the University of Colorado. And one of the problems here with generating something looking like a learning health system is that all of the investigators have to get their own funding. And so it does become a project by project evidence generation with buy-in afterwards on the part of the health system. And of course, that is really a very inefficient model. Do you have advice about how you could translate your learnings into an environment like this? And particularly, one of the other problems we've had is that there's a whole Q&I infrastructure that all the hospitals buy into. And in fact, activities where we are trying to integrate with the learning, with the health system are seen as competitive with those efforts, or almost, they're very threatening to those people. So it's a very different environment. And I'd love your thoughts about how you can translate what you've learned.
Well, that's a shame. I have so much. We need 45 minutes to adequately talk about that question. It's a very rich question. First, I want to dispel the notion that that our research institute is any different from any other soft money shop. Our researchers need to, you eat what you kill. And that is the model. And so that's why I mentioned, like, I will buy time from, like, I have a budget and I can get time from these investigators and statisticians, et cetera. But they are largely independently funded scientists. And so it's a mixed model. And then there are a small number of us who have a chunk of FTE on this work. We tend to be later stage investigators as opposed to early stage investigators, right? Because this does not, currently this doesn't really help you get, it's not on the direct causal pathway to getting grants. It can be helpful. I think you all understand, preliminary data and partnerships and all of that. Ideally it should, but it can be seen as a distraction. The bigger question is, I don't know that I know we haven't solved this. And Sarah, in my introduction, mentioned that we have a training program. I think some of you are on this call may be involved in this ARC and PCORI funded learning health system training program that has 11 centers of excellence around the country. And we're training early stage investigators. This is very high risk work for early stage folks because I can't tell you how many times we have a project that is going, we've got an intervention, it's getting implemented, we got an evaluation, and then staffing issues, layoffs, financial problems, and the health system says, no, we can't do this. So it is high risk, and from the solution we need on the academic side is that if we want our scientists to be working with care delivery, we need to pay them in a way and incentivize them in a way that gives them the freedom to do that, and the sort of year over year, so they don't fall off a cliff as they engage in this work, and they can really bring their value to the organization. And on the health system side, I mean, you're talking about QI folks competing with research. Well, that's just a non-starter. Like that makes no sense, right? And so because they all want the same thing, it's all about the patient. You want better care for the patient. You want more affordable care. You want the care teams not to be burned out. Like we all agree on the quintuple aim. So getting to that place where they don't view each other as competitors that's the first place to start. And the way we've done that is to say, how can we help you? Like, what do we have that will make your problems, that will address the problems you have or remove barriers for you? So it's a lot of stakeholder engagement, a lot of, building trust over time. And we had to do a lot of peeling back because they see researchers coming to them and they think, this person is going to ask me to do their, to be involved in their grant. And they know that grants take a long time and they don't give you results, in forever. And they're rigid and like all of those things that we do because that's how research works. And so they're scared of working with us. So, I can understand where they're coming from. And, to some extent, you need to sort of leave some of that at the door and say, how can we partner in a way that your needs come first? But very hard for someone to do that if they're early stage.
Thank you, Paula.
You're welcome.
Those of you joining us, we have just a couple more minutes. We can maybe take one more question and take a look at the chat. We would love for everyone to complete our evaluation and tell us what you thought about today's seminar. Any last questions?
It looks like Dr. Glasgow has said, in these rapid lit reviews, did you restrict to published literature or use gray literature and known contacts? We use published literature for the most part. Our methodology is peer-reviewed literature, and when we have to rely on gray literature, we put lots of brackets around that work. We want to be very cautious about diluting our value, and we're very guarded with our conclusions so that we don't overpromise. Thanks for that question, Russ.
And one other question a little earlier about the quintuple aim. I think a lot of our audience today are familiar with the triple aim and the quadruple aim. You've used the term quintuple aim a couple times. Can you just
so
that one real quick?
Yeah, so care team experience is important, and some people talk about provider experience, but we all know that care is provided by not just physicians. So the whole care team, if the humans who are taking care of us are under stress or not respected or exhausted, then we are not going to get the best care. So we need to take care of those humans so they can take care of us. And the last one is equity.
Great, thank you. We are coming up on the hour. I want to thank you so much for coming and talking about your model and examples of how you've implemented it at Kaiser Washington. Dr. Harrison has pointed out that tomorrow you are part of a D&I workshop. So if people want to hear more from Dr. Lozano about her work and how it fits into dissemination and implementation in health sciences or in learning health systems, I believe that is tomorrow from 2 to 3. And we're so grateful to have you. For those of you who are still on and attending, please make sure you fill out our evaluation. We'd love to hear what you thought about today's talk. Thank you so much.
Bye-bye, everyone.